Good evening, everybody. I'd like to welcome everyone to the new year. Happy New Year, 2018. How many people watched the end of the football game last night? I didn't make it either, but golly, that was amazing. That was a stunner. Happy New Year. I want to welcome everybody here tonight. I'm looking forward to this. I think it's going to be a lot of fun. Does everybody know, by the way, who's in this picture? Who's on this slide? Who's this? This is Sir Joseph Lister, okay, the father of antisepsis, the founder of the Royal College of Surgeons of England, Alfred Blaylock and Vivian Thomas. This is the Blue Baby operation developed at Vanderbilt and Johns Hopkins. Anybody recognize this person in this picture? John Gibbon, who developed the heart-lung bypass in Philadelphia, although Denton Cooley thinks that he developed it in Houston. William Halstead, Chief of Surgery at Johns Hopkins, and Emil Theodore Kocher, who at 33 was the professor of surgery at Bern Clinic in Bern, Switzerland, and won the first Nobel Prize in medicine as a surgeon. 9 surgeons have won the Nobel Prize in medicine and physiology. I want to welcome two of our newest applicants to the Fort Worth Surgical Society, Dr. Eileen Chu, Dr. Ananya Majumdar. How'd I do?
Very well.
Thank you all for coming tonight. Also, I like to always welcome guests, nurses, residents, fellows. Thank you for coming tonight. I want to thank, as always, our Moncrief partners, Dr. Argenbright and his team, and we are spoiled more month by month. This is actually a announcement for future speakers. We do offer 1 hour of Category 1 CME through UT Southwestern. If you are going to be speaking, contact Jonathan, Justin, or myself. We can get you set up for providing 1 hour CME credit through Southwestern. It's nice because if you attend a meeting before going home in your car, you can call this number, give them the event number, and get your hour of CME, or you can do it online. I want to remind everybody of the current Fort Worth Surgical Society Executive Committee. If you have any questions, ideas about future speakers or R.J. White speakers, any issues, please let us know at any time. A quick review of our schedule for the rest of the year. February 13th, Dr. Gordon will be talking about the treatment of rectal cancer. Dr. Yavadi's programs, chief resident, who's actually here tonight, Dr. Patel, will be talking to us. Topic to be announced in March. Dr. Charles West, a new vascular surgeon in town, will be talking about thoracic outlet syndrome. Maybe. He's changing his topic seemingly week by week. The R.J. White annual lectureship in May will be a first this year. This is, I think, the first non-surgeon who has spoken or will speak to our society. Dr. Miller is the current president of the American ERAS Society. He's a big into the enhanced recovery after surgery paradigm, and he'll be talking to us about the importance of ERAS. So May 17th on your calendar. Now, I do want to thank Dr. Dwayne, the current new chief of surgery over at JPS, for putting tonight together. It was really her wonderful idea to give an award to her former chief, Dr. David McReynolds, and to invite our speaker tonight, Dr. Phillip Edmundson. I think I'm going to turn it over to Therese to talk about Dr. McReynolds, and then to introduce Dr. Edmundson, who's a very attractive, interesting fellow, and she'll talk about that. And we're looking forward to your lecture very much. Dr. Dwayne?
So I felt kind of badly because I'm on call, so I had to show up in scrubs. But then I realized how better to honor Dr. McReynolds than to show up in scrubs, because many of you know him, which most of you do. I have never personally seen him in anything but scrubs, other than for maybe one 1970s long suit that he wore with sunglasses at the resident graduation. I really can't do Mac justice, nobody can, and his shoes are huge to fill, and it's truly an honor to be able to serve as the new chief for John Peter Smith. But in the transition, our group, Dr. Ziegler and Dr. Anderson and Dr. Bayouth and Putty and the whole group, we batted around the idea of what would be the best way to honor Mac. And we really thought about the type of person that Mac had been clinically and his dedication to John Peter Smith. And when you think about it, you know, he's the classic old school football player type surgeon. And I remember when I interviewed at John Peter Smith, and I was in the middle of the interview with him, and he gets a phone call. He's like, "Yeah, I'll be right there." And he's like, "Yippee! I'm not even on call, and I get to go to the operating room." And I thought to myself, that is a far cry from any chair that I have ever met with on my string of interviews. I think it would be pretty cool to work with this guy. And that's the type of guy he had always been clinically. Excited to be there, excited to be in the operating room, excited to work with the residents, excited to serve his community, which his entire career was dedicated to John Peter Smith. And so as we batted around the idea, we thought, and it was, I think Mark Bayouth really coined the phrase, the servant's heart. Because at the end of the day, Mac's heart was that of a servant. He came to serve the patients in the community of John Peter Smith, and that's the legacy that we want to continue with the new group and the growing group going forward, and also to emphasize to the residents and the fellows and the medical students who we have the privilege of training and working with. So as we put this together, we thought to ourselves, how do we build the progress that's already been made based on what Mac and people like Dan had already done over the years, and pave the way for the future. And so as we looked to that, we looked at the types of residents and who we had the privilege of training, who were technically excellent, hardworking, essentially ran the show over there, and how do we encourage that and foster that from an academic standpoint. And so as we were considering what to do, we thought, what better way than to create this legacy in perpetuity with an annual award. And so we decided that it would be best served for a chief who had earned his or her stripes, who had demonstrated that his heart was that of a servant, both clinically being excellent, as well as academically being excellent, as well as being a committed member of the John Peter Smith community through resident education, student education, and involvement in improving quality and research throughout the institution. And so as we thought about that, and all the chiefs are absolutely wonderful human beings, but at the end of the day, we decided that Phil Edmundson really embodied what we were trying to achieve in this year's class. For all of you who know Phil, you know him to be a very mild-mannered, thoughtful, polite, professional individual. He is also an incredible academic researcher. He's had a number of podium presentations and a number of awards to his name for all the phenomenal academic investment and achievements that he's had through his very already short career. It is always a wonderful compliment to any professional and any staff to have someone that you truly respect go and do what it is that you do. So for people like Dan and me, who are acute care surgeons, the best compliment you can give us is to go ahead and do an acute care surgery and a critical care fellowship, and we are just blessed to have you amongst us. He will be joining Ronnie Stewart down in San Antonio in the near future to pursue a critical care, surgical critical care training, and we couldn't be more thrilled. And so with that, he then, as per his usual, very thoughtfully decided on this topic, which is surgical education in the modern era, and that was related to the fact that David McReynolds was all about surgical education. So without further ado, I'll hand it over to Phil so he can educate us on this topic.
Well, thank you for that introduction. I want to thank the Fort Worth Surgical Society as well as John Peter Smith Hospital for selecting me to be the recipient of this award. I am very grateful. Although this presentation doesn't cover a clinical topic, I hope that you all will find it interesting and that it will generate some good discussion at this and future Fort Worth Surgical Society meetings. When I was asked to give a presentation on any topic of my choosing, it seemed fitting that I should pick a topic or speak on a topic that Dr. McReynolds spent a career promoting and defending, namely the notion of resident autonomy. I firmly believe that Fort Worth and the county hospital that it supports is one of the best examples of a training institution that encourages autonomy among its surgical residents. This is a testament to the efforts of Dr. McReynolds to ensure excellent surgical training over a nearly 4-decade career in a constantly changing graduate medical education landscape. Fort Worth and John Peter Smith Hospital should be commended for continuing a long tradition of excellent surgical training, and I hope this presentation will shed some light on some of the forces and realities that threaten contemporary surgical education, and perhaps guide us towards some solutions that will help us continue to train excellent surgeons for tomorrow. As you might expect, I have nothing to disclose. I'll use this outline for my talk, and I'll try to keep my remarks brief. If anyone has any questions or if anything's not clear at any point, feel free to interrupt. Ask questions at any time. I was recently at a dinner party at the Texas Surgical Society meeting, and I was speaking with a friend of mine who's a chief surgical resident at another large training institution in Texas. And since it's been a few years since we had seen each other, the conversation quickly turned to war stories from residency and our experiences over the last few years as we grew from interns to chief residents. At some point, he turned and asked me if I felt prepared to begin practice in general surgery right after I graduated from Baylor. I responded that yes, I feel confident that I could enter practice as a general surgeon after my training at John Peter Smith and at Baylor. Sure, there were things that I wish I had seen more of, that I would not be entirely comfortable doing by myself, but overall I was excited to graduate and get to work. In turn, he confessed that he was looking to join a general surgery practice that would complete his surgery training. He felt at the time that he would not be prepared to practice general surgery at graduation from his residency. This was a shocking admission to me, and it reflected a growing unease that's starting to make its way into the literature over the last several years, namely that graduating general surgery residents no longer feel prepared to practice general surgery. This crisis of confidence comes at a time of frequent and significant changes in surgical education, as well as broader changes within the field of general surgery. Thus, it's hard to identify an individual catalyst that's driving this perception. For example, a recent review looking at almost a quarter century of case logs from the ACGME revealed that there was no significant change in the number of cases performed by graduating surgery residents, even despite duty hour restrictions and other changes in the field of surgery more broadly. Given that the case volume and operative exposure is largely unchanged, what then is causing this unease amongst graduating surgery residents? After all, patient acuity in general has increased over the last several decades according to Medicare data. So trainees are exposed to and theoretically comfortable with more and more complex patients. Similarly, hospital admissions have increased and hospital stays are shorter over the same time period with increased turnover, thus exposing residents to patient encounters more and more frequently than ever before. While it's difficult to measure, I think that the slow but gradual erosion in resident autonomy, coupled with increasingly stringent resident duty hour restrictions, is at least partly to blame. Before exploring how that's happened over the years, I think we should pause a little bit to discuss what exactly we mean by resident autonomy. And then hopefully we'll conclude the talk with some suggestions for how we can preserve it within the confines of modern GME. Without getting into a debate on semantics, I'm going to use resident autonomy to describe that side of the spectrum that borders on unsupervised practice. In college, I wrote my senior philosophy thesis on the concept of patient autonomy in American medical ethics. And now as I approach the end of my surgical career, it's sort of fitting that I should talk on resident autonomy. Clearly this is something I'm drawn toward. I think that the term resident autonomy is probably something of a misnomer. How we use the term and what it should mean are two very different things. Despite this, it's clearly become part of the common vocabulary and has recently appeared several times in the medical literature. Regardless of its philosophic roots, the term resident autonomy has come to mean a degree of independent thought and decision-making by residents. And like I said, represents one end of a spectrum between supervised and unsupervised practice of medicine. The idea that resident autonomy is a spectrum of preparedness for unsupervised practice is convenience for at least two reasons. In the first place, this avoids equating autonomy with independence, strictly speaking. Residents should not, by virtue of their inexperience, practice medicine independently. To do so would defeat the purpose of a residency. It also sets up an unreasonable expectation. Even senior surgeons who do not practice medicine in a vacuum. We are surrounded by colleagues, consultants, nurses, therapists, and others that can help us navigate complicated patient care. We should avoid thinking of residency as needing to produce practitioners who will function in a vacuum or independently. Instead, we should focus on producing surgeons that can work within the context of a medical community and provide that care safely without supervision. More than anything, this requires trust and high expectation from the staff and mentors that teach us. The other benefit of this understanding is that when resident autonomy is considered as a spectrum, one allows for degrees of autonomy. A resident thus does not have to have complete or none, but rather residents with different levels of experience and competence can be entrusted with varying degrees of autonomy, various tasks. This becomes important when we try to develop strategies for preserving autonomy, as it allows for discussions of how to increase autonomy even amongst interns, without setting unrealistic expectations that they should be able to, or ready to practice medicine. The goal is to produce a senior resident who can identify sick from not sick, to operate or not to operate, and to carry out safe and effective operations and appropriate postoperative care. Invariably, conversations about decreased resident autonomy harken back to the training of previous generations as a comparison. And so I think it's worth taking some time to discuss where we came from in surgical education and trace how we got to where we are now. Prior to the 1900s, medical training in the United States was limited to obtaining a medical degree from medical school. Around that time, several schools were beginning to crop up that would essentially offer degrees for minimal work in exchange for sizable fees, thus producing a rather inconsistent product. Serious practitioners would seek additional training overseas, mostly in Germany. William Halsted and his colleagues at Johns Hopkins were the first to establish a formal graduate medical training program or residency here in the United States. Under his leadership, one entered an internship, usually for 2 years, followed by an indefinite period of time as a junior resident. During this time, one lived at the hospital and was expected to be available around the clock every day. Progression to chief resident or house surgeon was pyramidal and was only granted by Dr. Halsted to a junior resident who was sufficiently prepared, and there was only one at a time. There was no time frame involved, and many junior residents left his residency without advancing to a chief year, and this was not considered a sign of weakness or incompleteness. It just was what it was. Those he trained went on to become leaders in surgery across the country at a growing number of newly opened medical schools and established residency programs of their own. Eventually, the American Medical Association would provide a list of approved residencies across the country, which was followed by the development of specialty boards, which would then certify graduating residents having had a consistent breadth of knowledge and were adequately prepared to practice medicine. Early residencies typically involved more than 100 hours of work a week, even after the residents moved out of the hospitals. Eventually, more structure was added, and a 5-year general surgery residency became the standard in order to sit for the Board of Surgery exam. In 1981, the ACGME was formed, which developed specialty-specific standards for residency training in the form of basic guidelines. But even at this point, work hours remain unregulated on a national level. In 1984, that changed with the death of 18-year-old Libby Zion. She was the daughter of Sidney Zion, a lawyer and journalist in New York. She had been admitted to the hospital with fevers, agitation, and paroxysmal jerking. At that time, her diagnosis was unknown, and accounts vary as to whether she told the providers that she took phenelzine, an MAOI for depression. The attending physician had approved her admission over the phone, and she was seen by an intern who wrote for Demerol as well as her general admission orders. Subsequently, the intern was called for persistent agitation and prescribed more Demerol and Haldol, but did not see the patient. The prevailing opinion in the medical record at the time was that the patient had a viral illness with features of hysteria. By the next morning, her temperature had risen above 107 degrees. She subsequently arrested and died. Her grieving father took the issue to court, in addition to publishing numerous pieces in the press about the care that she had received, lamenting that an intern who'd been awake for more than 20 hours with 40 other patients in the hospital and limited supervision could not have provided appropriate care. That's to be debated. He was convinced his daughter's death was the result of inadequate staffing and poor supervision at the teaching hospital. His articles and lawsuit led the New York State Health Commissioner David Axelrod to establish a commission led by Bertrand Bell, a prominent primary care physician at Albert Einstein Medical Center, to evaluate the training and supervision of physicians in New York. The commission recommended that residents should not work more than 80 hours per week and no more than 24 hours consecutively. This was in spite of the fact that the Bell Commission identified lack of supervision as the primary shortcoming in the case of Libby Zion, rather than overwork and sleep deprivation. Several years later, the ACGME set duty hour restrictions in 4 specialties and limited call duty to every 3rd night, with at least 1 day off out of every 7. However, it was not until 2003 that duty hour restrictions were placed across all specialties after pressure from the public and Congress and threats that the government would use the OSHA to enact restrictions on the if the ACGME failed to do so. In 2008, following heightened public awareness of the impact of medical errors in the U.S. medical system, the Institute of Medicine was commissioned to further study the issue and review residency work hours as a source of medical errors. They recommended an additional requirement of a 5-hour nap for any shift lasting greater than 16 hours, which I find amusing. Again, under pressure from the public and Congress, the ACGME revisited and revised the duty hour restrictions again in 2011 to include limits for interns to shifts of less than 16 hours and strongly recommended that residents learn skills for strategic napping. At the same time, they also revised the common program requirements to include more specific instruction on the types and degrees of supervision that was required of junior residents. Thankfully, the recommendations set out by the ACGME largely left the specific determinations of appropriate levels of supervision to the local institutions, which I think was wise. Nevertheless, as programs worked to develop demonstrable evidence that supervision was occurring in order to meet ACGME site visit requirements, policies and procedures became codified that had the net effect of drastically increasing the role of attending physicians to oversee residents. Leading us to where we are today. Now, in all of this, there was very little evidence to support any of the decisions that were being made or any of the policies that were being set forth. Not surprisingly, there was also significant dissatisfaction, especially in the surgical community, with the duty hour restrictions. And there was no evidence that any of these changes had any effect on patient safety. The ACS recently supported a prospective trial to evaluate these changes using a comparison between the standard duty hours and a more flexible set of duty hour requirements. This is the first trial. The results purported to demonstrate no difference in patient safety and increased resident satisfaction with their training with a more flexible duty hour restriction schedule. This led to the removal of the 16-hour restriction for interns, and I think demonstrates the power of research to effect change. Overall, the study had serious flaws. Outcomes measured likely were not affected by duty hours. Predominantly, major morbidity, death, and major complications from surgery. I think that these outcomes likely were not affected by duty hours precisely because of erosions in resident autonomy and changes in resident supervision that have been occurring over the last several decades. It's fairly infrequent that residents perform operations in the absence of or without the knowledge of an attending. So to look at major outcomes like death and major complications from surgery probably fails to capture the effects of sleep deprivation on surgery residents. So I don't know that we can draw any strong conclusions from the first trial. And this also demonstrates the difficulty at studying how these changes affect us and our training. When we make universal changes across all residencies, we lose the capacity to evaluate comparison groups and to look at one compared to another. And so it's very difficult to conduct studies like this and gain meaningful data. More recently, in 2015, the Spotlight Working Group published an expose after an orthopedic surgeon at MGH blew the whistle on the practice of concurrent surgery after a spine surgeon in the Department of Orthopedic Surgery had a series of complications on patients that were scheduled for complicated procedures at the same time as he was scheduled to perform other complicated procedures down the hall. In one instance, a patient was paralyzed from the neck down. In another instance, a patient had to have revision surgery shortly after their initial surgery. MGH responded that while the surgeon was in fact covering two cases that happened simultaneously, that the practice was common and allowed specialists to perform operations more efficiently using experienced residents and fellows. This would allow patients to receive the care that they needed more quickly and prevent delays. They also noted that the complications of these procedures were not necessarily unexpected. They were difficult, complicated patients. They also subsequently fired the whistleblower. The Spotlight team published a series of publications about this as well as a short video. And this created significant public backlash about the practice of running two rooms. In 2016, the Senate Finance Committee staffed a special subcommittee to evaluate the practice of concurrent and overlapping surgeries. They leaned on the American College of Surgeons to come up with guidelines to instruct if this practice was safe and how it should be performed. They used their power as the oversight of CMS and threatened to change the payment by which physicians could get paid for doing surgery if the ACS did not provide guidance. The policy of using overlapping surgery was subsequently allowed and acknowledged by the ACS as a common practice. But the practice of concurrent surgery, or performing two major operations at the same time, was prohibited, except in emergencies. Congress has since instructed CMS to evaluate centers for compliance with this policy, and this effectively ends the practice of running multiple rooms at the same time. Clearly, forces both within and without medicine are working against historic models of surgical training. The end result is beginning to threaten the confidence and abilities of graduating surgery residents. I think, unfortunately, that I don't have any great solutions to this problem. The first step is admitting that there is one. We need more research to evaluate and monitor the effect of duty hour restrictions on surgical training using meaningful metrics. I think we also need to consider the effects of creating a then versus now culture. By instituting the 80-hour work week, we necessarily set up a comparison between then and now. And you can imagine the effect that that has on the current generation of surgical residents. Imagine an attending surgeon standing with a young resident, teaching them an operation, and that resident could be performing admirably the steps of the operation. But to hear a remark about how training just isn't as good these days as it used to be can cripple the confidence of a surgeon, a young surgeon, who may or may not be doing just fine. And I think that that is something that's hard to capture in the literature, and it's certainly something that's hard to research. But it's certainly something that we can do something about locally here. With respect to autonomy, locally, each institution needs to encourage a culture of progressive resident autonomy using data to drive expectations. This requires trust from our mentors, and it requires ownership of patients by residents. More research is needed to evaluate the new Milestones program, which is coming down the pipeline. And we need to be open to the idea of exploring competency-based pathways. After all, Dr. Halstead's model of surgical residency training had no time frame associated with it. Perhaps we need to be open to the idea of returning to that model. The Milestones, as I said, is in its infancy. Surgery was the last of the ACGME-approved residencies to adopt the Milestones program. For years, internal medicine has been using this, and it's worked seemingly fairly well to improve resident satisfaction with their evaluations. I think there's an opportunity here to use the Milestones as a tool to allow residents to be granted various degrees of autonomy. If a resident is told that they've met certain milestones, the expectations and the bar has been raised for that resident. We should entrust those residents with certain areas of practice without strict oversight. I think if we use the Milestones in that fashion, we'll have a more fruitful feedback experience for our residents. And I think the opportunity is there if we're looking for it. I also think that we need to develop good data and productive research as to what residents can and cannot do on their own. I think that we need to evaluate safe practices for residents to be doing with minimal or less supervision so that they can grow in their autonomy and their decision making and begin to practice medicine with the safety net of a training institution behind them. There's some interesting work out there. This was published only a few months ago, comparing the outcomes between senior surgeons and general surgery residents at appendectomies. The only difference that was found, looking at over 1,600 cases, was an operating room time of 9 minutes longer for the surgical residents than for the attending surgeons. And this is using data from before the time when an attending surgeon had to be present for that operation at that institution. Data like this is hard to come by. Because of the structure that we're in now, it's hard to evaluate how we compare to procedures in the past and generations in the past. Number one, the data isn't there. And designing a trial like this now is impossible to do. But I think that the opportunities are there, and we need to strive to find them where we can. And I think residents can use research to drive change in their training. Thank you all for your attention. I'm looking forward to any questions and any discussions that you guys want to have.
I think the current generation of residents has a much bigger challenge. I was thinking as Phillip was talking, a much bigger challenge in their training because they are dealing with decisions about open surgery, laparoscopic surgery, which a lot of us didn't have in our residency, and robotic surgery. So you all have a bigger challenge, I think, than we did. We will open the floor for discussion. Pretty big crowd tonight. Dr. Ravati.
Well, first of all, I want to thank you for a very thorough, unbiased history of this. As the DME, DIO, and program director for an ACGME program at Medical City, certainly we're bound by certain things being common program requirements, all programs, and then program-specific requirements. So you're correct, there's a blur between surgery and the other. I'm going to tell you this, there are 10 surgeons in the country that have been picked by the Surgery RRC, appointed by Tom Nasca, called Milestone 2.0. Surgery is the first RC, and I'll be representing one of the 10 surgeons in the country on Milestone 2.0. We're thoroughly going to look at milestones. We're going to look at that. There's been a lot of discussion on autonomy and moving up along the chain. As you know, ACGME requires very specific supervision protocols and policies. They rate you on that as an institution and a program. And certainly we need to take that and move that into the milestones, because that is where the surgery milestones can become to really do this for us. The problem that we have, and I'm going to tell you, when I put my hat on as executive director of the Board of Surgery, we have a higher fail rate on oral boards, both the American Hospital Board of Surgery and the American Board of Surgery. We feel there are a lot of components to that, but some may be exactly, maybe not so much work hours, but maybe more the autonomy given and the ability to work through very difficult, complicated surgical problems, cognitively. So very well done, and good luck to you in your career.
Thanks, sir.
Dr. Brotherton.
You pointed out earlier in your talk that the bioethics definition of patient autonomy is not the same as surgical resident autonomy, and you further pointed out that you didn't think that being unsupervised and being autonomous were the same thing. But I never did hear you say what your definition of autonomy was. That would inform your talk a little bit better.
Sure. I hesitated to open that can of worms because I could talk about autonomy as a term for hours. If you less than that. So
And his boss is sitting right here.
yeah, exactly. So short version, autonomy in its original form means to legislate for yourself. So to set rules and guidelines for yourself. In this country, unfortunately, when that term migrated into the medical world, it got transposed and transitioned to meaning independence. It means freedom of choice to do what you will. I think I prefer the first term, which is autonomy is the ability to make rational decisions and choose one thing and not another. And for us, as residents, what the literature uses the term resident autonomy, what they're meaning is preparedness for unsupervised practice. Can this person practice medicine without someone supervising them?
It sounds like you're going back toward the classic definition that your decisions would be honored. We use that for patient autonomy, and I think that's the correct way to go. I agree with you.
I think that's a very good distinction, because all you gray-haired physicians and surgeons in the room, we were proud, but yet think back. We were never independent. We always had attendings. We always had atone for our successes and mistakes on weekly visit rounds and so forth. We were never independent, and that was actually comforting. We always had backup help. Somebody in the back have a question? Hand went up. Dan.
At the Sages, one of the talks was the guy from the Netherlands who described their residency, and it was pretty interesting in that they spend most of the time in the OR. They delegate all the floor work to someone else, and I think their hours are down to about 60, and talking about going even lower. And I'm just wondering if, in your preparation, do you see things coming out of Europe that will affect us? Will we become shift workers? Will we work 12 hours and we'll just be in the OR, and a hospitalist will be taking care of the patient on the floor? I dread the thought, but I kind of wonder if that's not coming.
There was an interesting critique paper that was written about the first trial that basically argued against the conclusions of the trial. And the conclusions of the trial were the duty hour restrictions are too narrowly construed. We need to open it back up and sort of take a step back to the way surgery training used to be. And the critiquer commented and said, you've demonstrated a non-inferiority trial. So basically what you've shown is that there's no adverse outcomes from the more restrictive duty hour setup. If anything, you should conclude that it's safe to do that, to restrict duty hours even further, and to talk about even reducing further the amount of time that residents spend in the hospital. And I think that there is an arm of people out there that are interested in that idea. I personally think that spending time in the hospital is an important part of surgical training. I think surgery and the surgical specialties are a little bit special because of that. Each operation takes several hours, and so in order to amass the appropriate number of operations needed to become competent, you have to spend a certain amount of time in the hospital. There's no way around that. I think if we get too narrow down that spectrum of limiting the amount of time you spend in the hospital, you're going to start cutting corners, and I think what we'll see is case volumes will drop off.
One of the things they are talking about, though, is extending the length of what you talked about earlier.
So that's the alternative, is that you can lengthen the programs. And I know that there's a working group at the college that's looking at that. They're looking at not only that, they're also looking at shortening general surgery down to 3 years and then adding subspecialty training after that. The end result would be a longer residency for everybody. It would be 6 years for everybody.
I think most of us here in the room with gray hair, when we went through there were periods in my training where I was spending up to 140 hours a week in the hospital, which means there's only 166 in the week. And 140 were being spent in the hospital. And you really, it was just all you were doing was hoping to survive. I think it was a terrible strain on the marriage. I think I really actually became kind of psychotic through part of that. I didn't terribly object to the hours. We overreacted a little bit, but I think it can be too much.
I would agree. And I think that part of what I realized when I was preparing for this talk and looking at these things is that we really don't have any data about any of this. A lot of this is conjecture and speculation. There's no NSQIP data that goes back to the time before duty hour restrictions. We don't have good data to suggest that the way we train surgery residents back in the day was necessarily better for patients than the way we're training them now. There's no data to support that conclusion. So I don't think that going back to the previous generation's training is necessarily the right thing to do. I think the better option is to buckle down and take a look at it. And the only way you can do that is if you're going to allow flexibility across the country between programs. You have to be able to say, this program over here, you're allowed to train residents for 6 years under a competency-based program. And this program over here, you're going to train residents over a 5-year period and make them sit for the boards. And at the end of the day, they're both going to be able to practice surgery. And then look at the outcomes, not only of the patients that they take care of while they're in residency, but also the outcomes of the patients after they graduate. And that's going to take years. And you got to have flexibility amongst the governing bodies to allow for different systems to be in place in order for us to get data to figure out what the best thing to do is. That's going to be the real challenge.
Are we running out of time to figure this out? Because all the data shows, at least last time I read about this, that we're facing a huge shortage of general surgeons the next 30 or 40 years. Are we running out of time? We have to figure this out, because will there be enough surgeons down the road to staff, and supervise residents, and shorter duty hours and so forth? Are we running out of time to do this if we have a shortage of general surgeons in the future?
Yeah, the timing wasn't good.
Yes.
I enjoyed your talk very much, Dr. Robert Turner. Over 50 years of practice in surgery, I've seen a lot. I trained in a hospital, 1,800 licensed beds, and we had rollers in between. It was resident upon resident teaching. Very little supervision by the staff, except doing elective procedures during the daytime. After being admitted hospital in 15 and 16, and myself, and seeing how medicine is practiced today, particularly by hospital-based physicians, I predict, and I'm not going to be around to see it, but in 20 years, the medical profession is going to be mere technicians to computer AI. And it'll tell you what to do, but you're going to have to put the data in. But then you need to be trained as technicians, of course, which will require the residency training that you had. I hate to see it go by the wayside, and I hope it doesn't, but a wonderful profession reduced to something like that. But I'm telling you, physical diagnosis as it existed, it does not exist today. In my experience, it's gone.
We're just going back to kind of your opening comments about you're talking to your friend, and he's saying that you feel confident to go out and practice as a surgeon, and he did not. And so I think some of it comes down to the program where you're trained, the culture there, and the experience that you get. And so I don't know, I think that ACGME's goal has been to try and standardize that among programs, and it's failed. And so I think that's where the question is, why has that failed? And so, and I don't know what the answer to it is, but, everyone talks about data, but I think you just have to look at the product, and I'm not sure that you can change, you're in a big academic center and maybe the culture there is different and they don't have a GPS. And so I'm not sure that you can create that in that environment. I think that's a bigger issue that isn't going to be able to be fixed by any amount of data that we can collect. So it's not really a question, just sort of, I guess, a general comment.
That's a different and also troubling problem.
Dr. Phillips.
Just a quick comment from the token internist in the room, but our specialty struggles dramatically with an identity crisis, and we restrict hours for our residents without any evidence-based strategy that shows that our internal medicine residents are better or worse than they were before. There was an editorial last week or so, and I can't remember if it was in JAMA or the New England Journal, that basically said face-to-face medicine, option B, kind of like what Bobby's talking about, is that as we see in primary care more and more of a shift away from human-to-human contact. Telemedicine, and Steve and I were talking about that at a function last night. Internal medicine struggled for a long time trying to distinguish ourselves from family practice. Now we find ourselves being challenged by, what is it, Steve? Advanced practice professionals. Nurse practitioners, physician's assistants who will spend a couple of years in an online program doing some kind of roll your own clinical evidence at some who knows where unsupervised clinic, and then think they can go out into the real world and take care of people without any supervision whatsoever. People want to go on the internet, they want to go on to UpToDate and think they can come out and practice medicine as competently as somebody who spent 4 years in medical school. So this whole trend of where training is going to go. Internal medicine people have talked about whether we need to lengthen our training time because the students, the residents don't spend as much time with clinical material. We've found the whole issue where you've got a group of internists who think they want to be hospitalists, so there might be one track for people who want to be hospitalists. There'll be another track in internal medicine for people who want to be medical subspecialists, and then another track for internal medicine doctors who think they want to work in a primary care office doing that kind of work. So, I mean, you guys at least have some kind of a physical skill that requires you to be involved in touching people. We're kind of out here in this sort of never land trying to figure out who we are and where we're going to go.
Jim Harper.
Jim Harper, I'm the token anesthesiologist here. In the past 5 years, I've noticed there are a lot of younger general surgeons who are facile at laparoscopic surgery, but a little bit troubled by open surgery. And I don't know what the requirements are for, or if you even have any, regarding number of laparoscopic cases versus open cases. Could you address that, please?
Sure, there are requirements. The majority of the cases that are required are not necessarily specified laparoscopic versus open, but we have specific requirements for open procedures and we have specific requirements for laparoscopic procedures, and then a broad middle category that can kind of go both ways. Unfortunately, at JPS, we do a lot of both. But I know that there are surgeons out there who are uncomfortable with one or the other. And I think, like Dr. Mencillo had brought up earlier, there's variances in the training programs across the country that produce an inconsistent product, for lack of a better term. And some people are exposed to more things to the exclusion of others. And that is a sort of separate but important problem.
There's a great business writer out there who writes great little books. His name is Malcolm Gladwell. And I recommend to you all, if you haven't read it already, a book called Outliers. He makes a point that nobody is born a genius, nobody is born excellent. You get good at what you do at about 10,000 hours. It's all about study and practice. So you won't become a good surgeon until you're about in your mid-40s or 10,000 hours in the operating room. That's what I personally discovered, that it's practice. It's a 10,000 hour rule, not just in surgery. It's in golf, it's in business, it's in whatever you do, it's in tennis, whatever you do. It's intense practice, and you sit down and you analyze. The best golfers in the world, they analyze why they missed that last shot in the Masters or the U.S. Open. You analyze your mistakes and you correct them and you practice fixing them. But it's 10,000 hours. Dr. Duane, do you have a comment about training or where we're going or what you think, how we can fix the problem? We've heard from Dr. Yervati. Whoop, we have one more. Al?
Yeah, the current requirement for ACG is 850 cases by the end of your cheat year. 200 plus of those have to be TA cases. So they don't define out laparoscopic is correct versus open or closed, just the number of cases at this time. However, the requirement expects you to have exposure in laparoscopic and robotic cases, but they don't define how many of each.
I think Dr. Turner.
Are you able to comment on the impact of fellowships on the 4-year surgery residency?
Sure. I think there's sort of two sides to the fellowship question. On the one hand, almost 80% of graduating residents in general surgery are now pursuing fellowship, which is why we have a problem or a shortage of general surgeons. At many institutions, the presence of fellows is seen to take away from some of the experience of the residents. And I think that is another challenge at developing residents that feel confident, comfortable, and ready to go into practice when they finish. If the cases are being perpetually put out on fellows and the residents are getting less and less of the pie, it becomes harder to produce a resident that's ready to go out and practice on their own, which perpetuates the problem, because then they go to pursue a fellowship, and then they're taking cases away from residents at the institution that they go to. Or at least that's the concern. We, fortunately, at Baylor and JPS have very limited exposure to the fellows, so it hasn't been an experience in my residency, but I know that that's something that is discussed nationally.
So, any other questions?
No.
Okay. So, just because it's 7:15.
Yeah.
So, the only comments I would make is, when I came here 3.5 years ago, I was quite honestly shocked at how technically superior the residents here were compared to the residency I left. And that was a quote unquote big academic center with, a lot of fellowships running through and a lot of support to the point where I felt uncomfortable because I was like, could someone please invite me into the operating room? Because I felt extraneous. I mean, they were that good. And I would just make 2 comments. One, as far as, things that we need to do to move forward, I would point out that I've got my whole row of phenomenal advanced practice providers here who, as we move forward to support what we're trying to do with training and education, they're integral because we're all part of the same team, and they're going to help support the residents to really maintain those technical skills and also be able to be good medical doctors. One of the many things that drives my husband crazy about me is I tell him, well, surgeons are medical people who actually know how to operate. And of course, as an internist, he believes differently. The other thing I would say is, as a member of the Executive Board of Governors, there is a pushback on shortening the training so that you're doing 3 years and 3 years. I do not see that passing anytime soon, provided that true general surgeons continue to be the leadership at the board for the American College of Surgeons, because we want to make sure that we've got good general surgeons who are capable of going out there and providing the services that need to be had, which is part of the challenge we're running into, right? That we don't have enough good people who can operate. So, I think as I thought 3.5 years ago, JPS continues to be a diamond in the rough as far as that's concerned, because the training the residents get, I think it's a nice balance. And I know my goal personally and the goals of the faculty who are helping to grow this program remain committed to the residency program as far as education in all facets, including the incorporation of our advanced practice providers, but also to make sure that you've got that autonomy in the true sense of the word, so that you're capable of introspection. It's more than just the technical. It's about how to know when you know and how to know when you don't know. Because that's just as important. Because, as my mentor, L.D. Britt, would say, he's like, you can teach a monkey to operate. What really matters is the judgment. And so hopefully the things that the more senior people in the audience continue to do is give you that judgment that you need. And so, Phil, you've done a phenomenal job, and we are so grateful for your time and talent. And here's a little token that does come with an honorarium.
Thanks, that's great.
We're so grateful. Thank you so much.
Just stand for a picture there.
Okay.
Of course.
Because Can you actually get me in the picture? I put on my Mac outfit.
We'll have a little 5-minute break before our business meeting, but I do want to conclude by thanking everyone for being here tonight. It was a terrific discussion, one of the best we've had in quite a long time, a very timely, important issue, especially for those of us who are advancing in age, and we're going to wonder who's going to be taking care of us when we're lying on that stretcher in the emergency room with a tender sore abdomen. There you go. Well, thank you all very much. I have the feeling tonight that the Fort Worth Surgical Society is very much alive and well, and thanks everybody for coming tonight.